35-year-old lady with thyroid swelling on the bilateral in front of the neck on a previous history of excision 3 year ago, sir.
And exercise, she underwent surgery?
Yes, sir, underwent surgery.
I can't see any scar. Whether there is a scar. So, look at the torch here, yeah. So there is a thuk satka Mataji. So there is a thyroid swelling which is recurrent, formed to hard in consistency. Both lobes involved. Trachea is almost in the central, I show you. But the important thing is she is presented along with a swelling in the scalp or actually in the skull. Right. This is where it is. And you can feel that there is a defect in the bone. Okay?
Yes, sir.
So probably a metastatic swelling of the skull. So what is the likely primary?
Follicular.
Yeah, so commonly you see that picture in your Bayesian law. I think that is the rarest of rare pictures. It is not. You see that very frequently in our body. The trachea is slightly pushed to this side, although I can also feel some lymph nodes. This is the left lobe, this is the right lobe, and that's the isthmus. But I can get below the swelling, just about. The carotid pulsations on both sides are felt normally. And there are lymph nodes in the level 5 on the right side. If you look carefully,
So even on inspection, the lower border can be seen while deglutition.
yes, and you can see that this is the trachea, and it is sort of in the midline, but this is the, can you give me the marking pen please?
Yes, sir.
निशान एक लगा रहे हैं, ठीक है? Took set again. See, on it. By just this one simple test you can make out. This is the entire gland. Formed to hard inconsistency, that's an old scar. Previous thyroidectomy. So maybe if you can get the record of the previous surgery, that would help. And this is the gland. So this is a case of
35 years lady,
35
youth thyroid
years
patient.
lady, clinically 35 years lady with a diffuse thyroid swelling, but it's actually nodular, you can't call it diffuse. A nodular thyroid swelling or multinodular goiter, it's the same thing, which is formed to hard inconsistency, likely to be malignant on account of it being hard inconsistency, has rapidly grown and importantly recurred. And associated bony metastasis to the skull.
And
So it's
cervical.
going more in favor of metastasis to, and also the cervical lymph node involvement. So it's a thyroid malignancy. Now the good news about thyroid is, we will of course subject the patient to the same triple test. History we have already taken, examination we have already done. Imaging will do high resolution ultrasound, followed by FNAC after doing thyroid function test. Same old story. And we'll also get a ultrasound of the neck to look for lymph nodes. Contrast enhanced CT scan to get a complete idea of the, she has no voice changes. So recurrent laryngeal nerve is not directly involved. So we will be able to get the clearance. And the management would be total thyroidectomy, because if you remove the gland, then the metastasis can be treated by radioactive iodine. That's the plan.
Yes.
Now to work up, so the investigations to confirm the diagnosis, I have already told you the triple test. To support it, we may need the CT is a good test for local infiltration and also the retrosternal extension, which clinically somebody has doubted. Then voice quality test, indirect laryngoscopy, soft tissue X-ray neck, and importantly, based on FNAC, we can take then the decision. For ultrasound, we'll use the thyroid grading, and for cytology, we'll need to Bethesda. The patient is young, which means good prognosis. What is the high risk? What's the age cutoff? Ages, MS, MESIS criteria. More than 50 years now. It used to be 45.
55 now.
55. It used to be 45 for males, 50 for ladies in the past. Now it is 55 for all. Above that high risk, below that low risk. Then the grade, the size of the tumor, extent of metastasis, MS, or gender I've already told you. So this is how you're going to plan this.
Sir, I have a small doubt. So, currently, what do we do with the scalp swelling? So, do we subject to FNAC or an imaging study for PET scan?
We'll do an imaging. That's what I said, CT. So CT would tell us. PET is not a great test for thyroid, especially.
Not avid.
Not very avid. So CT, we will just have a look at the CT. If it shows an osteolytic lesion, we're thinking more in terms of metastasis malignancy. Sometimes, there was a case which I had done 8-10 years ago. It's a pulsatile swelling, which is very vascular, so then becomes not pulsatile. It can happen with follicular. But we'll need to do that. Do you see something in the eyes? I was thinking, I don't want to. There is a bit of a stare. Isko dekhiye? I'm doing it. Fix the head and you can see. जब दो हो जाए बताना. एक दिख रहा है अभी देख पा रहे हो? If you're able to converge, all right. इसको देखते रहो.
So some lag is there in the right eye.
Some lag and also there is some stare. We
Yes,
need
sir.
the thyroid function test to be done before we do an FNAC, okay? Which is Talweg sign. And the उंगली देखो ऊपर चलो इसके साथ साथ चलना सीधा wrinkles are
Lost.
lost. चलो ना उंगली को देखते रहना है आपको हाँ करते जाओ घबराओ नहीं. If I don't fix the head, see there was an error.
Yes, sir.
गर्दन नहीं मोड़ना है हाँ मैं रोक रहा हूँ आपको.
Loss of forehead wrinkles.
That is Geoffroy's.
Yes,
But
sir.
we need to very rarely, is that unusual? Very rarely are malignant thyroid swellings toxic.
Yes, only
Because malignant
30%.
thyroid don't produce thyroxine.
It's a cold nodule.
10.
So usually it's cold. But in 10%, 8 to 10% you may find activity. So let's check for it.
Yes.
But definitely that is connected. That's what you are asking?
Yes.
Let's look at the CT. Head and neck CT we get done. Follow it. This is the portion they are worried about, see? So you may miss out. There can be a link and then it will be extending. So there is a retrosternal element. But not, it is possible to approach it
Yes,
through the neck.
cervical.
Through the neck we'll be able to take it, and that's the osteolytic metastasis.
Both the
The
cortex.
cortex are both destroyed,
Inner and outer cortices.
inner and outer both are destroyed, and more likely to be metastatic. Surya, does that answer your question, or is still doubt?
Internal calcifications are there.
And see inside the metastasis, a very good point Junaid just mentioned, calcification. Can you see that?
Yes.
That goes also in favor of it. So, really good. So that calcification, both cortices gone. I'll take it as malignant or metastatic unless proven otherwise. And I don't need an FNAC for this. So I would like to do total thyroidectomy and follow it up with radioactive iodine. That's my plan. But I need a good FNAC after thyroid function test. So subject this patient to triple test, not quadruple, we don't do that. And which would mean good history and examination, which we have done. High resolution ultrasound, which we are going to do, get the thyroid staging. You can even do elastography, which is supposed to help you further.
Resistant index.
Yes. Third, thyroid function test before you do
FNAC.
And FNAC we need so that we can plan our therapy accordingly. The lymph node that I was feeling on the right side, I finally found out that's a part of the gland itself. That's the right lobe. So there is no lymph node in the neck. There is a metastasis to the skull. So in the crude sense, follicular is likely.
Right, sir.
But you never know, it could be medullary or any other. So we need a FNA before we proceed. If FNA is suggestive of medullary, Sapriya, what would you add in the investigation?
Sir, calcitonin.
Serum
tumor
calcitonin.
marker.
Good, very good. We would like to do a serum calcitonin then. And MEN workup. Your answer should be, I'll do an MEN workup. Which would mean ultrasound of the abdomen, ultrasound of the neck, we are already doing it. So it becomes important to get that triple test done properly. That's the plan of the case. Any other question?
No, sir.
Vinay,
So it's a recurrent case, so it will be a little technically challenging to do a.
it will be a technically a challenging case because it's recurrent, yes. And try to, that's what happens when surgery is done and it's thrown into the bin. You should always have a record of where was the surgery done. You don't need to mention, okay, don't mention. So that record, if you can trace, it will be useful. We will at least know what did they do last time, right? Okay.
Thank you.
What